Disorders of sexual development, or DSD. I know this topic can feel like a super confusing mix of genetics, hormones, and anatomy. But what if I told you there's a really clear, logical pathway behind it all? That's exactly what we're going to do in this explainer. We're going to build that pathway from the ground up, step by step, so you can absolutely nail this high-yield topic for your exams. Okay, let's jump right in with a classic clinical puzzle. You know, the kind that shows up on exams and really trips people up. Picture this. You have a patient. Their genotype is 46XY. They have internal testes, but when you look at them, their external body appears completely female. How on earth is that possible? Stick with me, because by the end of this, you'll know exactly how. The answer to that puzzle, and really the key to understanding all of DSD, is right here in this flowchart. Think of this as our roadmap. As you can see, everything, and I mean everything, kicks off from one single point: the undifferentiated gonad. This is the common starting block for both male and female development. So what does that even mean, undifferentiated or bipotential? Well, it's actually pretty simple. For the first 5 to 6 weeks of embryonic life, the gonads are basically identical. They have the potential to become either testes or ovaries. They're just sitting there, waiting for a specific signal, a command, to tell them which path to take. And that brings us to the most critical moment in this whole story: the fork in the road. That little undifferentiated gonad is standing right at this fork, and just one single factor is going to decide its entire future: male or female. So what is it? What's this master switch?
Right, so if the embryo is 46XY, it's got a Y chromosome. And on that Y chromosome is the master switch gene. It's called SRY, that's for sex-determining region Y. As soon as that SRY gene flicks on, it's like a command. It tells the undifferentiated gonads, okay, you're becoming a testes. And once that testes is formed, it immediately turns into a little hormone factory, pumping out two crucial substances: testosterone and anti-Müllerian hormone, or AMH.
Now, these two hormones, they have very specific jobs. Testosterone gets to work building the internal male plumbing, the Wolffian ducts. It also gets converted into DHT to build the external male genitalia. At the very same time, AMH has a different job: destruction. It actively gets rid of the Müllerian ducts, the structures that would have become the uterus and fallopian tubes. So you see, it's a two-part mission: build the male stuff and tear down the female potential. Okay, so what happens in a 46XX embryo? Well, the key thing here is what's not there. There's no SRY gene. And without that SRY signal, the undifferentiated gonad just follows the default path. It develops into an ovary. And since there are no testes, there is no anti-Müllerian hormone being produced. That means the Müllerian ducts are left alone. They're allowed to persist and develop into the uterus, fallopian tubes, and the upper part of the vagina. It's the default setting, you could say. All right, now that we have the normal pathways down, we can start to see what happens when things go off track. Let's start with 46XX DSD. So here, we're talking about a genetically female individual, 46XX. The core problem, the single issue at the heart of this, is that the fetus gets exposed to way too many androgens, male hormones, while it's developing. And the most common cause of 46XX DSD, and listen up because this is super high yield for your exams, is a condition called congenital adrenal hyperplasia, or CAH. It's an autosomal recessive disorder, so a child needs to get a faulty gene from both parents. The basic problem is a bottleneck, a block in the adrenal gland's steroid production line. And the most common culprit for this block is a deficient enzyme, 21-hydroxylase. So let's walk through that hormonal cascade step by step. The 21-hydroxylase enzyme isn't working right. That means the adrenal gland can't make enough cortisol. The pituitary gland up in the brain senses this low cortisol and freaks out. It starts screaming at the adrenal gland by pumping out tons of ACTH. But the adrenal gland is overstimulated, and the path to cortisol is blocked. So all those raw materials, all those steroid precursors have nowhere to go. They get shunted down the only open road, which leads straight to producing a massive excess of androgens.
So what does this look like clinically? What do you actually see? Well, internally, everything is female. You've got the 46XX karyotype, ovaries, a uterus. All the internal female structures are there. But on the outside, that flood of androgens has caused masculinization, or what we call virilization. And this results in ambiguous genitalia, maybe an enlarged clitoris that looks like a small phallus, or fused labia that resemble a scrotum.
Okay, Let's switch gears completely now and talk about 46XY-DSD. In this situation, the person is genetically male. The SRI gene worked, the gonads became testes, so everything started off on the right path. The problem is somewhere downstream. Either the testes aren't making the hormones correctly, or, and this is key, the body just can't respond to them. And the classic textbook example of this, and here's the answer to our puzzle from the beginning, is androgen insensitivity syndrome, or AIS. Now, in AIS, the testes are working just fine. They're making plenty of testosterone and plenty of AMH. The problem isn't the signal, it's the receiver. The receptors are broken. The cells all over the body have faulty or just plain missing androgen receptors. So they are completely, totally blind to that testosterone signal. And this really highlights the core conflict in complete AIS, doesn't it? Genetically and gonadally, this person is male, 46XY with testes making testosterone. But phenotypically, their actual physical body is female. They have female external genitalia and are usually raised as girls. You'll see a vagina, but it's often short and ends in a blind pouch. And crucially, there is no uterus.
So let's piece this together. Why does this specific phenotype happen? Well, first, the testes make AMH. The AMH receptors are fine, so it works perfectly, and the Mullerian ducts disappear. That's why there's no uterus or tubes. Simple enough? Second, even though testosterone is flooding the system, the tissues can't see it, so the male Wolffian ducts also disappear. So what's left? With no male signal being heard, the external genitalia just follow that default female pathway we talked about. And then, at puberty, all that circulating testosterone gets converted into estrogen in the body's peripheral tissues, and that's what causes breast development.
Okay, so understanding these conditions one by one is great. But for your exams, the real challenge is being able to tell them apart, especially when they show up in a clinical case, often presenting as primary amenorrhea, someone who hasn't started their periods. So let's get practical and look at how to differentiate them.
Pay close attention here, because this table is pure gold for exams. Let's run through a scenario. A patient presents with primary amenorrhea. You notice she has well-developed breasts, but an ultrasound confirms she has no uterus. Your top two differentials have to be AIS and MRKH syndrome. So how do you separate them? Easy. You check the karyotype. AIS is 46XY, MRKH is 46XX. Now, what if you get another 46XY patient, but this one has a uterus, but no breast development? That's your classic picture for Swyer syndrome, where you have non-functional streak gonads that produce no hormones at all. See? If you just follow this structured approach, check the karyotype, look for a uterus, and check for breasts, you can solve these cases every single time.
Whew, okay. We have covered a ton of ground. So let's do a super quick high-yield recap to make sure the most important concepts are really locked in your brain for exam day. First, always remember that sexual development is a logical cascade. Chromosomes lead to gonads, gonads make hormones, and hormones create the phenotype. Got it? Second, the SRY gene. It is the switch that decides that first fork in the road. Third, for 46XX-DSD, like in CAH, the problem is too much androgen. And fourth, for 46XY-DSD, like in AIS, the problem is the inability to respond to androgen. And the final rule, always correlate the karyotype, the gonads, and the anatomy to figure out what's going on. So if there's one thing you take away from all this, let it be this. In sexual development, genetics proposes, but hormones and their receptors dispose. The genetic code might write the first draft, but it's the hormones and the body's ability to listen to them that really determines the final story. If you can understand that cascade, you've mastered disorders of sexual development.